essentials of molecular monitoring in chronic myeloid leukemia. And Pankaj is professor in charge of clinical hematology at the PGI Chandigarh. He is, according to his own submission, also a COVID treatment expert now. So if you have any COVID-related questions, Pankaj is the person to talk to. Pankaj, you have 10 minutes
Yeah.
and the screen is yours.
Yeah. So I would, from my screen, I would, make the presentation. So the topic which is given to me is essentials of molecular monitoring in chronic myeloid leukemia. Now, why do you need to monitor CML? The reason is that you want to do a response assessment. Why do you want to do a response assessment? Because of various reasons. And these are to predict long-term survival, predict cure, and thus stopping therapy, decreasing the dose of medication, need for change of treatment, and for females, pregnancy decisions. And how do you monitor CML? You can monitor clinically, you can monitor hematologically, cytogenetically, or molecular. And then we will discuss what is the frequency of monitoring. Now, just take an example that you have a car, Maruti car, and you actually want to visit from Puri to Vijayawada in Andhra Pradesh, and it takes 12 hours by a routine Maruti car. And if you divide from Puri to Brahmpur, it will take 3 hours. From Brahmpur to Vijayanagaram, it will take another 3 hours, and then another 6 hours to reach Guntur or Vijayawada. Now, let's say you start from Puri, but it takes to 5 hours to reach Brahmpur, which basically means that you need another 7 hours to complete this distance. That means either you need to change your car. That means if you are on imatinib, then you need to change to the second line TKI, or you double the speed of your Maruti 800. That means you double the dose of imatinib, which I feel is still an option for very poor Indian patients who cannot afford the second line TKI. So this is what is monitoring. So let's go to the monitoring, and we will discuss about what is the clinical monitoring. The clinical monitoring is done by resolution of splenomegaly and resolution of extramedullary disease, if that is any. The hematological remission is when there is a normalization of WBC count and there are no abnormal or immature cells in the peripheral blood film, and the platelet counts are less than 4.5 lakhs. Then cytogenetics is done by conventional and FISH by looking at the chromosomes, and we have major cytogenetic remission and complete cytogenetic response when there are 0% Philadelphia positive metaphases. However, the problems are this is done on bone marrow samples, which is painful, and it is a tedious job to look at the metaphases, and only 20 metaphases are checked, and sensitivity and specificity increases if you look for Philadelphia in more than 20 metaphases. And you can also do from the peripheral blood, where you have to look at the 200 cells, and but it is little costlier than the conventional cytogenetics, and there can be false positive 5 to 10%. Now, the most commonly used is molecular monitoring by PCR, and is the gold standard. It can be done from the peripheral blood, and it is a very sensitive technique. There was problem in the standardization, but now, fortunately, most of the labs are well standardized, and they are giving on international scale. Now, once you have a clinical remission, you have to look at the hematological remission, look at the cytogenetic remission, and then look at the molecular remission. However, once the patient has achieved hematological remission, you can directly go to molecular remission also, because these days, we don't have many labs who are doing cytogenetics. Now, the next is frequency of monitoring. So, clinical is and hematological. Generally, you do a clinical examination and CBC 2 weekly until the patient achieve a complete hematological response. Then you do monthly for 3 months, and after that you do 3 monthly. Whereas cytogenetics and molecular actually are done generally 3 to 6 monthly. And as I said before, you don't do the cytogenetics these days unless there are clear indications. You directly go to the molecular monitoring, and these are the gold standard. Now we come to the response assessment, that once you are monitoring the patient, what are you like what are you actually doing the assessment. The first is predicting long-term survival. So this paper, which is quite an old paper, looked at 5-year follow-up of patient receiving imatinib for CML by Brian Duker. And here, patients who have achieved complete cytogenetic response within 12 months, they did not progress to accelerated phase or blast crisis by 60 months. That means at 12 months, you could predict that this patient will do well over a period of next 5 years. And these are the graphs. The patients who did not achieve a hematological response, they did not do well, whereas the patients who achieved a cytogenetic response, they did well. And then this paper came by David Marin, who actually looked at the BCR-ABL transcripts at 3 months, and they could predict what is happening at 8 years. So they looked at 282 patients, and the patients who achieved BCR-ABL less than at 10% at 3 months, they did well over a period of 8 years. The next is predicting cure and thus stopping therapy. We know about various stop imatinib and stop second generation TKI studies, and this is the study, STIM-1 study, long-term follow-up of French stop imatinib, where they looked at 100 patients, and we all know that almost 40% of patients were able to achieve a sustained molecular response. Then is decreasing the dose of medication. So if you know that the patient is in molecular response or sustained molecular response, you can actually decrease the dose from 400 to 300 and sometimes even 200. That means that the patient will actually have decrease in the side effects and you have good quality of life of these patients. Then if there is a need for change of treatment, so somebody who is actually not achieving the desired response, you can consider changing to nilotinib or dasatinib, and these are the Tidal 2 studies as well as some other studies. And then for females, the pregnancy decisions. So this is one of the paper looking at managing pregnancy in CML. So if the preconception planning, so if the patient has durable MMR at least for 24 months, you stop the TKI at the start of menstrual cycle, conception and pregnancy, and then you monitor this patient by qPCR every 6 to 8 weekly. Whereas with assisted reproductive technology, you see the patient achieve CHR or MMR, then stop TKI, and then commence in vitro fertilization and oocyte collection and restart TKI. So this is, you can help in patients becoming, starting the family life. Now, the next question is what is optimal assessment? And Dr. Tulika has already, I think, discussed about the ELN 2020. I'll just discuss a little bit about the 2013 before going to 2020. So the optimal response was the one which is associated with long-term outcome. Failure means the patient should receive a different treatment to limit the progression, and warning is that the patient is responding, but you require more frequent monitoring. So, it's like you are driving a car and we keep on evaluating at different time points. You have a red, yellow, and green. Red basically means failure. That means treatment is going to fail in near future. Yellow is a warning. That means you have to be careful. You require more frequent monitoring and may require change in treatment. And green is that the patient is in optimal response and there is no change in treatment which is required. So at 3 months, the optimal is less than 10%. At 6 months, the BCR-ABL of less than 1%. And at 12 months, it should be less than 0.1%, which means it is optimal. And then you have, based on the levels, you have warning and failure. And anytime after 1 year, if the BCR-ABL is more than 0.1% or there is additional changes in chromosomes, that means it is warning or failure. The methods to do this is from CML 2020. So these are the housekeeping genes, ABL1 or GUS. You can take that. And this is the optimal warning and failure by CML 2020. And for patients aiming at TFR, the optimal response at any time is BCR-ABL of less than 0.01. That means a deep molecular response or molecular response of 4 or 4 point, sometimes 4.5. A change of treatment may be considered if MMR is not achieved by 3 to 4 years of time. And the loss of MMR indicates failure after GR. Finally, not everything that can be counted counts, and not everything that counts can be counted from Albert Einstein. on the monitoring of CML. So finally concluding, the chronic myeloid leukemia is now a curable cancer. Multiple treatment options are available. Monitoring as an essential component of the treatment in the journey towards curability, and molecular monitoring of BCR ABL gene at international scale is currently the gold standard technique. With that, I thank you very much for your kind attention.
Thank you very much, Pankaj.